Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dislocated IOL. This patient actually had a dislocated IOL about 10 years ago, and I iris sutured the pre-existing three-piece lens, and it was doing quite well. But then he came in more recently and noticed a change in the vision, and the lens had started to descend. This is a high myope who was previously vitrectomized, and you'll be able to see that in the case. And you'll see in my modifications for the Amani technique, I do a trailing haptic first technique. I also place the trailing haptic through the incision in a U-shaped configuration, which makes it easier. I use the bevel of the needle as a docking platform. I leverage the bevel to guide the haptic through the needle. And lastly, which is the most important part, and that is making sure that the lens is well centered, and I utilize the conjunctival markings to get a well centered lens with minimal tilt as possible. So as you can see here, this lens is quite dislocated. I'm using a cotton tip to dry the conjunctiva, but as I do this, you can see the lens is dangling by a thread. And so I'm going to use the end of a cannula that was pre-marked, and I'm going to mark the limbus. I'm going to use a cannula to help me find 180 degrees away, and then I'm marking with another cannula at the limbus. I'm using a caliper 2.5 millimeters posterior, marking that point, and doing the same thing on the other side, marking 2.5 millimeters back, and then marking 2 millimeters adjacent in an L-shaped configuration, first on the right side and then on the left side. I'm going to indent with the back end of my trocar, and you'll see it leaves a nice indentation. About 4 millimeters back, I'm going to tunnel through the sclera and then dive down, entering the vitreous space with the trocar. And then I'm making a contralateral incision through the limbus, and then making a tangential incision for my AC maintainer. Now, my mistake here was, as I put the AC maintainer, I put it in too close to the limbus, and I started to get fluid under the conjunctiva, and so I had to cut the conjunctiva there. I make another paracentesis incision, and then I'm injecting dispersive viscoelastic using the pupil and the angle as a shelf to help coat the corneal endothelium. I'm holding the eye and then using my blade in a triplanar corneal incision technique, making a vertical groove, tunneling through the cornea, and then dimpling down and then entering. I tried to go in with the trocar, but you can see the eye is so soft. But I straighten it out. I'm able to go in. You can see the trocar is underneath the lens and bowing up the lens. And so I get a forceps through a contralateral incision, and then I'm able to grasp the lens, making sure it's completely secure. I come out with the trocar, and then I'm using a Maltzman to help prolapse the lens into the anterior chamber. You can see I was using the Maltzman to get around the optic and haptic on that side, and then I'm going to do the same thing on the other side using the Maltzman to get underneath the iris, pushing the iris down, and by doing so I'm able to sweep the other haptic up into the anterior chamber. So it's time to try to cut the lens so I can take it out, but I see that there are small holes in the lens, and as I use these disposable MST scissors, I try to cut it, and it actually just breaks the scissor. So rather than perseverating, I go ahead and widen my incision. Clearly this is not a lens that can be cut, and so I go ahead and widen the incision with the blade, and then I'm going in with another forceps, pulling the trailing haptic out, and then grasping the optic with the forceps, coming out with the left forceps, and then using both forceps to grasp the lens and then pull it out. And when the lens comes out, you can see the pupil is nice and round in this post-vitrectomized eye, and there is no vitreous in the wound or the anterior chamber. So I try to place my trocar, but you can see the eye is so floppy in this soft vitrectomized eye. So a pearl is to grasp the actual trocar with the forceps so you can place the vitrector in the eye. So I'm going to go ahead and do the vitrectomy, and that was in high speed. And then because I had to widen the incision, I'm going to go ahead and close the main incision with 2 separate tononolon sutures. Again, I'm doing this in high speed. You want to close the main incision because as you're doing your manipulations, you don't want fluid coming out of the eye. it collapses the anterior chamber, it causes corneal stria, and it just makes it much more difficult to do the surgery. So this is a trailing haptic first modification of the Amani technique. I inject the lens, but then I'm using a forceps to externalize the leading haptic, and then I'm carefully delivering the optic, making sure it comes out planar. And as long as it comes out planar, then I'm able to deliver the trailing haptic, and the trailing haptic must be delivered swept to the right so that the optic comes out correctly. So you sweep to the right and the lens is in the correct configuration. I'm placing the trailing haptic through the incision in a U-shaped configuration, which is very important. I'm injecting some dispersive viscoelastic to coat the corneal endothelium and push the lens back. I'm bending the right side needle about 9 millimeters from the tip, 80 degrees, and then the left side needle is going to be bent at the hub 80 degrees. And it's important that the bevel is going to be bent towards the approach of the haptic on each side. So I'm going to tunnel from the first mark, tunneling 2 millimeters, diving down into the vitreous space. I'm holding the trocar to help give me better control of the eye. And then with the forceps, I grab the apex of the loop, and this is a perfect position so that I can grab it, dock the haptic on the bevel of the needle, flattens it out, and then I'm able to straighten it and then thread that needle. I disengage the needle from the syringe, and then I lay it down. And then I'm going to internalize the leading haptic with forceps. I'm going to use the forceps to hold the eye, and then the left side needle is going to tunnel 2 millimeters from the first mark to the second, diving down and into the vitreous space. I'm going to use microforceps then to grasp the haptic. I'm grabbing here and I feel like it's a little bit too close to do the docking, so I grab it a little bit further away to dock it on the bevel of the needle, and then it goes in very nicely. I externalize the left side needle, and you want to make sure you're parallel to your entrance. You can see I'm straightening out, but because I'm a little bit not straight, I had to straighten it out here, and I'm holding the haptic with the forceps. I've secured it, and then I'm going to cauterize that first haptic. And you see it creates a small little bulb. I do the same maneuver on the other side, pulling it parallel to the entry point. I'm putting forceps right at the opening to make sure that I'm able to grasp the haptic as it comes out. You can see the haptic comes out. I'm inching it to make sure not too much of the haptic is externalized. And then as I'm holding it, I'm using my other hand to get the cautery and create that small bulb on this side as well. You want to push the haptic flush to the sclera, making sure that bulb is really very close to that beginning part of the sclerotomy. You don't want the bulb to be sitting on top of the sclera. You want it to be embedded in the sclera, and then you want to reapproximate the conjunctiva over it. In this case, the pupil is small. You can't really tell if the lens is well centered, but it is very well centered and it's nice and planar. I'm going to do a peripheral iridectomy using the vitrector, and I'm going to try to perform a temporal iridectomy. This is a right eye, and so I'm doing the peripheral iridectomy on this special setting. It's got high vacuum and then small aspiration rate and a very low cut rate. So you can get a very controlled PI. I begin to hydrate my incisions laterally and then on the roof of the incision. And then I pull the trocar out, massaging the eye, pull the AC maintainer out and do my vitrectomy. You see I put the eye at a very low IOP because I don't want to encourage any vitreous to come forward. But again, this is a vitrectomized eye. You can see there's quite a bit of billowing of the iris. Again, in a post-vitrectomized eye, there's quite a bit of billowing, and that's why that PI is so important. And now I'm hydrating my incisions. So the techniques are using the trocar, I was able to go underneath the lens and save it from falling backward, using micrograspers to pull the lens up, using the Maltzman to prolapse the lens completely into the anterior chamber. And in this case, it's nice because you want that pupil to be smaller because it actually captured the lens from descending. I want to do the trailing haptic first technique, externalizing the leading haptic, and this makes trailing haptic fixation so easy. I place that trailing haptic do the main incision in a U-shaped configuration so I can easily grab it and then go ahead and thread it into the needle. You can see that I use the bevel of the needle. It's very, very important to use that bevel to face the approach of the haptic. I'm able to dock the haptic on the bevel of the needle, flatten it out, and then advance it very easily. And I do the same thing on the other side. I like to pull out the haptics one by one, but as I pull it out, I want to cauterize the first one and then cauterize the second one. You can see that the technique was very smooth and streamlined. When learning this technique, the hardest part is threading the haptic into the needle. But once you become more familiar, this becomes a little bit more routine. Really, the hardest part is the centration and the tilt. And that's why the conjunctival markings are so important. And you saw I used holding the trocar on the right side and then holding the main incision on the left side to give me very good control of the eye when I'm passing that needle through the sclera. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.